Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the program. This is Aebhric. This week, we have a presentation from one of our Masters of Austere Critical Care graduates, Harrison Steins, who talks about swimming-induced pulmonary edema, or SIPE. This presentation was part of the Medicine in the Mediterranean Conference in January and February 2026. We hold this conference in Malta each January. We would like very much to see you at the end of January for our next MiM in 2027. Now, here is Harrison.
Go ahead and get started. Hi, everyone. My name is Harrison Steins. Very happy to be here. I'm coming from Colorado, USA. Very excited to be presenting on swimming-induced pulmonary edema. And thank you to Dr. Noel for his conversation earlier. I hope that in the next couple of weeks, you find that your citations have increased because I've got some papers coming out where you're definitely cited. So it's great to get to talk to you here today and get to talk to everyone about swimming-induced pulmonary edema. And we're going to touch on a couple of different topics. So altitude, ultrasound, austere medicine. And a study that I did, I've been working on for a couple of years, but actually ended up becoming my own thesis. So this is kind of a combination of medical school that I go to in the United States that I've finished up with and CoROM. I picked up the master's thesis or the master's in Austere Critical Care a couple of years ago and just graduated yesterday. So that's exciting. So talk to me about any of that. Talk to me about triathletes. Talk to me about kind of anything you do in Austere Critical Care and go from there. A little bit more about me. If you come to Colorado where I live, also not biking or really do anything, including medicine, but in the middle is kind of where I live. So I have a background in EMS. I was in pre-hospital care for a number of years. Following undergraduate, I worked in resource-limited medicine and the event medicine space. Worked with Burning Man for a number of years and months. So a little bit different space there, but I would argue that some of the pathology is just as interesting as some of the combat zones. If you talk about mixing ketamine and Molly and sex in the desert, I can definitely talk to you a little bit more about that and how you end up treating it or don't. I have done medical school in the United States and kind of just finished up that. I'll be matching into emergency medicine residency in about a month. And I did another degree in biomedical science, kind of focusing on research. And then I've worked in counterterrorism, bioterrorism, and public health emergency preparedness for a large government organization in California for a number of years prior to going to medical school. And then have a large interest in research and also ultrasound applications, but then high altitude pulmonary edema and drug trials for that. So why am I talking to you about what you'll learn is a disease, swimming-induced pulmonary edema with extremely low prevalence, less than 1%. And I think a good way to think about it is using an analogy of what austere clinicians and providers start to think about when they go into new settings. So we can look at a 4-year-old child presenting in 2 countries in the United States at a tertiary care facility where they're up to date on their vaccinations and they're presenting with a fever. You know that they'd had great care from prenatal care all the way through where you're presenting at them. You can look at everything in their chart and you come up with a couple of things on the differential for the pediatric fever. Great differential, and you can go ahead and start to treat it. But now when we get to an austere setting with the same child that's presenting, no idea of their care, presenting with family members that have died from diseases that you don't see in a large tertiary care or a first world and more developed country, you need to start to broaden your differential. I think that's what CoROM and all the clinicians in this room are really good at, is understanding the places that you're going to and how you need to broaden your differential and focus on the diseases that you're going to see in the population that you're looking at. And how you need to think a little bit broader about your maybe first world country that you're coming from and really understand that context matters. So in small incidence disease that we're seeing or pathology, swimming-induced pulmonary edema, I think it's important to think about the context of what we're going to be learning today and the population that we're going to be looking at. So we have some learning objectives. So understanding the pathophysiology of SIPE, which we call it, the factors that contribute to fluid accumulation in the lungs during immersion, identify the common symptoms in the clinical presentation, and then how we differentiate it from other things. We're going to discuss some diagnostic methods used in identifying SIPE and look at clinical assessments and imaging techniques, and then review management strategies. And then finally, evaluate new research developments in SIPE and look at new identification, patient demographics, and future directions for where we're going. So we'll start with the case. This was a case that we saw in Boulder, Colorado, which looks at about 5,000 feet. And I would convert it right now, but I'm talking up here and there's no way I'm going to be able to do that into meters. So they're competing in an Ironman 70.3. So this is a half Ironman distance for those that are not familiar with Ironman. And I'll still do it in the US system, which is unfortunately worse than everyone knows here. But biking 100 miles, swimming just about 2.2 miles, and then running a full marathon. So this was a half distance, so half of each of that. This was a 27-year-old female that came in from Rochester, Minnesota. They dropped up to the fifth of the swim, so maybe 1,000 meters into it, with a steady ease, heart rate of 80, BP of 118/72, normal respiratory rate, and O2 was fine on room air. No past medical history that we could elucidate, no mental health history. Their current meds was Zyrtec that they took every day for normal allergies. And then this was their fourth half Ironman, and they'd been training for about 6 months. They had no idea why they had dropped. They didn't have a feeling of anxiety. Their EKG was fine. We had some point of care labs. The electrolytes were fine. But we didn't have much else in the tent of the Ironman. So this is something that we started researching, and we've seen a little bit more. What we did have, though, was a point of care ultrasound. And this is essentially what their point of care ultrasound showed. If people are familiar with doing ultrasound, this has been on the whole time, I hope. You can see multiple BIONs, and this was the number of BIONs present in each lung field. So they had 7 in the upper, 4, 6, so lots of BIONs, including some sort of pulmonary edema present in the lungs. The patient wasn't presenting with a cough or faulty sputum. I actually had no idea why this was happening. We followed the patient thereafter. They didn't end up going to the hospital. They just dropped from the race. And we had pretty close follow-up with this one patient as an individual case report, and found out that all of this resolved shortly thereafter, within the next day. Later in the week, they went to an urgent care clinic, got a chest x-ray, and presented with no signs of pulmonary edema on chest x-ray and no signs of wheeze on auscultation at that secondary clinic. So we started thinking, is this swimming-induced pulmonary edema? So essentially, fluid build up into the lungs, leaking into the alveoli. Worst cases, you can start to see breakage of these capillaries and the frothy, bloody sputum. So someone coughing up essentially sea foam with blood-streaked sputum. So relatively rare diagnosis, but increasing as studies are increasing to find it. And I think that's one of the interesting things about osteomedicine research and wilderness research as a whole is most of the things that at least I have seen within the realm of wilderness research present initially as case reports. So 1, 2, 3 findings, because it's really hard to do a randomized controlled trial when your total number of swimmers is going to be 1,000 or even less than that. So we started out as case reports and kind of moved on from there. So overall, swimming-induced pulmonary edema. It's characterized by an acute onset of cough and dyspnea, sometimes accompanied by excessive sputum and hemoptysis when swimming in the open water. Importantly, it's not associated with aspiration, so drinking water that could lead to, or swallowing water while swimming that could lead to drowning. And it generally resolves within 24 to 48 hours. Where it can get dangerous is there have been recorded cases of death where swimming-induced pulmonary edema or pulmonary edema as a whole, not related to cardiogenic causes or other found causes, have resulted in death from some of these swimmers. So it was first described in divers in 1981. It was also reported in ocean water athletes, and then it's reported in combat populations. So I think for all of us working in any of these environments, I would consider the combat populations kind of our conflict, but then swimmers and divers also austere settings because you may be managing some of these patients. Say you're on an offshore rig and you have divers coming up and you only have the resources that you have on your rig, or say you're just managing the tent at a long endurance race, whether it's somewhere abroad or in their home country, the resource limited environments. So I think that as we start to think about the diagnoses that people may have, this can go on a differential as well. So what is SIPE and why does it happen? If you look at the literature, it's not fully elucidated, but we have a couple of reasons as to why it happens. As I said before, it's pretty hard to get randomized controlled trials, and it's also pretty hard to get trials that follow hemodynamics and look at lung physiology and how the physiology changes in these athletes. If you were to come to some of the races that I've worked at and ask some of the athletes in the middle of their Ironman to come out and play an ADG and maybe get a lung ultrasound and maybe just pause their race for a little bit, there's no way you're going to be able to do that. So we built our study into the Ironman protocols where anyone that came out of the water, either because of a medical concern or didn't make time, was required to go through at least entrance into our study. They needed a medical evaluation and could opt into our study if they wanted to. So we see SIPE pathophysiologically for a couple of different reasons. So immersion creates a blood shift from the peripheral vessels to the body core. So as you go lower, you start to get colder, and you vasoconstrict in your periphery, essentially increasing central blood fluidity. We also have measured pressure breathing and forceful and rapid inspiration, or reduced cardiac compliance, and sometimes you can see arterial hypertension in divers, but this is less thought out in the literature. We have an increased circle resistance with the exposure to cold water and physical exertion. So we think about all of these causes creating a couple of different things. So hydrostatic pressure overload that can create fluid leaking into the alveoli in the lungs. Cold water can intensify this pulmonary stress. The hemodynamic load is increased through exercise, so you're increasing cardiac output. You're increasing contraction and expansion of muscles in the periphery, in your legs and your arms, essentially pushing fluid to the core. And then you can also think about some of the individual susceptibility factors, which are starting to be talked a little bit more about as the pathophysiology of SIPE is starting to be more discovered, but those can be genetic and anatomic predispositions. We have a couple of cases coming out of military that are twin cases where either one or both twins got swimming-induced pulmonary edema, and those help us start to look a little bit more at how this pathophysiology evolves when we can't do like a big RCT. My point of study is looking at altitude, moderate altitudes, and getting into high altitudes and seeing how does altitude affect lung physiology from a swimming-induced pulmonary edema perspective. We all know that high altitude pulmonary edema is a result of decreased pressure forces, essentially pushing fluid into the lungs as someone's starting to breathe faster. But how does this play into swimming-induced pulmonary edema? So who is this actually affecting, and kind of why does this matter at an austere medicine conference? We look at a couple of different groups, looking at triathletes, Navy SEALs, and divers. And we see that there have been deaths in all of these. I think that one of the most interesting case reports was actually in an aqua jogger, so a fitness class in a local pool that included immersion, and someone was jogging with weights on their legs for a form of aerobic fitness. What we do see is that among combat swimmer trainees training at open sea swimming, prevalence has been reported between 1.8 and 60%, depending on the severity. The prevalence of the symptoms is highly suggested of, or in triathletes is highly suggested of a prevalence of about 1.4%. And later on in our study, we talk about around 1% as our prevalence. And then a Swedish study, the largest of 322 open water swimmers, showed that adjusted odds ratio for SIPE was 8.5 times higher for women as compared with men. And our study started to show that there was some influence of altitude and moderate altitude on increasing the prevalence in men. So when you start to think about SIPE, I think it's a cool diagnosis and really interesting from a pathophysiology perspective, but the medical clinician providing care, if you see someone coming out of the water with exacerbation of breathing, shortness of breath, possibly pink, frothy, bloody sputum coming up, I wouldn't put SIPE at the top of my list. I think that's really important for us to know as we start to go into austere settings and think about what are some of the lesser known presentations of disease As with any emergency, you obviously need to focus on the life threats, your ACS, your acute hypoxic respiratory failures, PEs, and infections as someone comes out. Once we started to rule all of these out, and we start to broaden our differential, I think SIPE is a really interesting pathology that can come into that differential. So how are we actually diagnosing this? So we see some acute symptoms of SIPE. So cough, dyspnea, hemoptysis, or the frothy sputum, wheeze, and chest tightness. And we diagnose it as an acute onset of dyspnea or hemoptysis during or immediately after swimming. Some of the questions that are important to ask are, was there inspiration of any fluid, of any water while you're swimming? If there was, you can start to think about external fluid collection in the lungs and kind of a dry drowning case. Then you can look at imaging. So chest radiograph consistent with alveolar filling, whether it's a CT, X-ray, or we'll talk a little bit more about ultrasound. And the hallmark is kind of a resolution within 24 hours. Some of the studies talk about hypoxemia as defined by an oxygen saturation of less than 92%, or an AA, alveolar arterial gradient, of greater than 30 millimoles of mercury. Some of our studies coming out kind of challenge this in thinking about patients that are coming out of the water, how accurate is your SpO2? Their peripheries are already really cold. I know for many of the people in this room, if you've worked with divers or swimmers and taking them out of the water and tried to get a pulse ox on their finger, or even taking someone in like severe shock, it's really, really hard unless you have like a central SpO2 monitor. When we were looking at altitude at moderate elevations, people were coming to us straight off the plane from a area with zero elevation, and we're already having lower SpO2s as well. So I think the context at which you're seeing these patients is also very important. What we saw from some of our studies was the incidence of non-traditional symptoms. So not the dyspnea, cough, wheezing, or increased sputum were also associated with some of the findings of swimming-induced pulmonary edema seen on ultrasound. So nausea, back pain, anxiety, fatigue. So I think it's important to have a broad differential of any of the patients that you're starting to see. So when you can diagnose this, what are the criteria as they exist right now, and how are they changing, and how can you use these as a clinician in the field to broaden your differential and include SIPE on it? So we had an oxygen saturation less than 92%. Lung rockets, 3+ B-lines. If we look at the Berlin criteria for acute respiratory distress syndrome, talking about prevalence of B-lines, it mentions bilateral lung fields or consecutive lung fields. In our study, we kind of broadened the definition of pulmonary edema to include a singular lung field, seeing evidence of greater than 3 B-lines. I think the question of how prevalent and how diffuse pulmonary edema is in swimming-induced pulmonary edema is something that still needs to be studied. Is it dependent on the side that the swimmer is breathing on? Is it dependent on the stroke that they're doing? Is it dependent on how long they've been out of the water? So this is something that still needs to come. But I think focusing on 3+ B-lines in a lung field is a great way of looking at pulmonary edema. And then later that evidence of alveolar filling or interstitial edema on chest X-ray or CT. So as kind of a background for lung ultrasound, I'm sure many of you do a lot of lung ultrasound, but this is how I like to think about it. 4 quadrants on each side. And then I take my lung ultrasound going through. We try and optimize our image. So in the bottom, I want to make sure I'm in the lung view. And then I want to make sure that my depth is set correctly. To properly visualize a B-line, you want it to extend from the pleural line to about 16 centimeters. I know I was initially taught from the top of the screen to the bottom of the screen, but you want to make sure that your depth is adequate to actually visualize that B-line, and make sure that it's not another artifact like a Z-line or not true evidence of artifacts from pulmonary edema. We then like to make sure that we have 2 ribs. So these black lines are rib shadows, which we call ribs. So make sure your Batman is up there. And then we can start to look at that pillow slide. And then we can look at the actual lung tissue and see if we can see evidence of B-lines, A-lines, its profiles of things, and then understand if there's any pathology or just normal lung tissue there. For the study, we modified the blue protocol, which looks at these 4 lung fields. We use 3-lung fields. I think that this is a really cool protocol to look up, and the next screen will have a larger image of it, that it's the bedside lung ultrasound in emergency. So if they're evaluating lung tissue, you can start to use this protocol. And Dr. Lichtenstein, who's a master of lung ultrasound and has published so many papers on it, wrote this protocol years and years ago. And I think looking it up after this talk was a great way to kind of refresh your understanding of lung ultrasound. But here's kind of the basics of it. Making sure that there's not lung sliding, kind of assessing, or making sure that there is lung sliding, assessing your ABCs to start, making sure there's no pneumothorax, and then seeing if there's presence of A lines or B lines or another type of profile to go ahead and start diagnosing pathology. So this first part of the talk is on SIPE as a whole, and then we'll get into the actual study a little bit later. But overall, you brought this patient out. The patient came from very, you see 16 B lines all over their chest. They have some anxiety. What are you actually going to do to treat them? So the very first thing that I like to focus on with treatment for SIPE, or really anything, is focusing on the beast that's causing it. So for Batman, if you're jumping into the water and trying to save a patient who's drowning, and there's a shark still attacking them, you need to focus on the shark attacking them first, because otherwise you're going to put yourself in harm's way. There's someone coming into you with SIPE, or you're getting out on a boat trying to treat them, the very first thing you need to do is take them out of that shark's mouth. So you need to take them out of the water. You need to get them calmed down if they're hyperventilating. You need to take off their wetsuit, because we know that external compression can increase that vasoconstriction in the periphery and continue shunting blood to the core and start affecting them that way. The next things that we can do are adding on oxygen, and then we can look at medications. There's been a couple of trials on PDE5 inhibitors like sildenafil. There's been some trials on dexamethasone, antibiotics, beta-2 agonists. The pathophysiology is different than, say, high-altitude pulmonary edema. So you're not going to be using any of your carbonic anhydrase inhibitors or things like that. So having an understanding of the pathophysiology, I think, is important. Why is this person going into pulmonary edema? Is it cardiogenic? Is it swimming-induced? And then you can start to approach it. So there's no randomized trials of psychotherapy. And remember that the hallmark of psychotherapy is a rapid resolution of the initial symptoms within 24 to 48 hours. So you can counsel the patient to understand that once they leave here, if they continue to have frothy sputum and continue to have difficulty breathing and shortness of breath, then they should follow up with the primary care provider or present to the emergency department for further evaluation. If that all resolves, then you can counsel them that it's probably okay to get back in the water, symptom dependent. How are we preventing it? So a pre-swim run-up is a great way to not shock your body. We heard it earlier, maybe you splash everyone with a fire hose full of very cold water, at least in an effort to prepare their body for what's about to happen. I think the combination of increased cold water, increased constriction from your wetsuit, and an immediate change from your walking at the starting line of the race to jumping in the water and being full force in a crowd full of people all swimming and tugging at your legs is a big jolt to the body. So having people warm up adequately before. Avoid excessive hydration before swims. And this point actually comes from the military. So UC San Diego and the Naval Medical Center was seeing that in some of the reported cases of swimming-induced pulmonary edema, their combat warfare swimmers were drinking 4 to 5 to 6 to 7 to 8 liters of water prior to their day's activities, because they were realizing that we weren't going to be getting any water for the rest of the day. So that massive increase in hydration essentially can overload the system. And if you're pushing all of your blood to the core because of both your exercise and the environment that you're in, and now you have an excess amount of fluid because of all of the water that you just took in, you could be putting yourself at increased risk for swimming-induced pulmonary edema. And then gradual immersion into the water, so kind of falling in like this. Long-term considerations and recurrence. This is talking about how we can use sildenafil, and some of the studies doing some work on PDE5 inhibitors to increase vasodilation. This one study found that SIPE is a form of hemodynamic pulmonary edema, and a reduction in pulmonary vascular pressures after sildenafil had no adverse effects on exercise and suggested that it may be useful in SIPE prevention. Similar studies have found similar things in preventing SIPE from recurring. So using 50 milligrams of sildenafil prior to racing may be effective, but is not currently recommended in any guidelines. The Wilderness Medical Society has, in their new CPGs, has about 3 lines on swimming-induced pulmonary edema, 2.5 of which is the definition of it. So the field is very much open for research. I will say that if you're talking with athletes in particular, adding new medications can very much be against like the World Anti-Doping Guidelines. So in counseling any of your athletes going into the water, focusing on optimizing their hydration strategies, their warm up, and anything else prior to medications may be best for their performance, both as an athlete in the event, and then to be in adherence with the anti-doping guidelines so that they can maintain their status as an athlete. So that's a big overview of swimming-induced pulmonary edema. We can go into what the CoROM thesis was and some of our studies. So this was a couple of our Ironman swims. We got out to them. This is a bunch of members on my study team, and just started taking an athlete questionnaire, taking demographics, understanding how well they trained for it, what type of wetsuits they're using, taking their temperatures, understanding medications and any previous histories, EKGs, a couple of labs, and then a point of care ultrasounds. This was all in an effort to answer a couple of questions. We were looking at confirming the incidence of swimming-induced pulmonary edema in endurance athletes, and we're also looking at comparing sea level to moderate altitude, so 771 meters and 1665 meters. The highest elevation swim in the United States is around 8,000 feet, just over 2,000 meters. If there's any higher in other countries, please let me know, and we'd love to come check them out, because I think continuing the question of how does altitude and elevation impact swimming-induced pulmonary edema and lung physiology is very interesting and still not borne out in the literature. We also wanted to assess the reproducibility of established sea level diagnostic criteria, particularly this SpO2 of less than 95% at altitude, just because we do know that SpO2s can be lower if you're coming from lower elevation to moderate or high elevation already. So including that in a diagnostic criteria is very interesting in the field as opposed to in the hospital. And then we wanted to evaluate the utility of handheld ultrasound devices for this field diagnosis. This was more born out of the ability to actually do studies and to make recommendations to clinicians in the field who aren't going around with a full echo machine. So started with our literature review. This is just a PRISMA analysis. We kind of went through everything, and you'll see this in Wilderness Environmental Medicine this month, and can get some credit for it if you do the quiz for like a farm or something. So kind of what we talked about earlier, that SIPE is the acute onset of cough, dyspnea, hemoptysis. It's in young, fit, and otherwise healthy athletes. And this is for 2 reasons. They're the ones probably doing all of these activities. They're the ones doing the Norseman races. They're the ones doing Ironman races, although I've seen many elderly individuals who would kick my butt coming out of the races in Kona and in Utah at the Worlds. And then symptoms generally resolve within 24 to 48 hours. Why it's difficult to diagnose and the incidence may be lower than what is true is because the symptoms overlap with asthma, panic attacks, aspiration and drowning. And rapid resolution means that if people are starting to feel better when they come out of the water and starting to feel much better in 2 days, then cases often go undocumented. Many people end up pushing through as well if they have some sort of coffee sputum blood that they're coughing up and they want to finish the race. If they've flown out for their families all flown out for, they'll continue to do the race. And so I think more cases go undiagnosed than anything else. It's few objective diagnostic tools during competition settings, which was one of the reasons that we wanted to bring the point of care ultrasound. The risk factors include the cold weather, negative static lung load, exertion, fluid loading, and low vital capacity. So our study looks like essentially we used a prospective cross-sectional design across 3 different races at moderate altitudes, evaluating adult athletes pulled from the water during or after the swim. They all received symptom screening and exam and handheld lung ultrasound and prioritized clinical care. So this is a cross-sectional design. Utah races, Colorado races, cold beverage. We had 143 evaluated out of around 10,000 participants. Those were the ones that were essentially pulled from the water. 103 completed the full protocol. took all of their physical exam findings, handheld lung ultrasound, and their history, and then did an adaptive group protocol where we had a 6-zone bilateral exam, and then we had ethical safeguards in place for everyone. This is what some of our setup looked like, and images from some of our cases. What are our results? So this is going to be a very busy slide, but I'll just kind of talk through some of the things, and probably similar to many of you, I go through the results decently quickly and then look at their discussion to see what I can actually pull from it. But out of 10,500 swimmers, we evaluated 143, and 103 completed the full protocols. We did evaluate people that ended up needing to be emergently transported to the hospital, or people with other conditions that were definitely more emergent, so they were excluded from the full protocol because of consent. We identified lung ultrasound that was positive in about 28% of our athletes with greater than 3 D lines across multiple lung fields, confirming the pulmonary edema. The overall incidence confirmed by lung ultrasound was about 0.37, which closely aligned with the sea level data of about 0.44. But we did have a subgroup analysis that revealed significant differences in male athletes at moderate altitudes, which were greater than female athletes. And the female incidence remains pretty consistent with some of our prior studies. Age was a contributing factor. The average age was 48 years in lung ultrasound positive patients, as opposed to 39 years in lung ultrasound negative patients. We saw non-traditional symptoms. And then we also saw that an SpO2 of less than 93% provided better diagnostic accuracy at altitude than the sea level threshold of 95%. One of our other big findings that's validated in the research is that crackles on auscultation had a poor sensitivity around 67% and poor specificity around 86%, which underscores their limited utility. So I think that this, for an austere clinician, is important to know. If you're hearing an absence of crackles on lung auscultation, it doesn't necessarily mean that fluid's not there. I think thinking about the diagnostic utility of this, if someone's not presenting with fulminant crackles everywhere, how severe is their pathology is also important to keep in context. So discussion, SIPE incidence persisted at moderate altitudes with some sex-specific differences, particularly an altitude-associated increase among males. We saw diagnostic thresholds validated at low elevation, but they may overestimate disease burden at elevation, necessitating an altitude-adjusted criteria. And then we confirmed that handheld focus was a feasible and reliable diagnostic tool in austere race environments, which I'm sure many of you already know. So where do we go from here? Increasing prospective cohorts at higher altitudes, exploring the overlap with high altitude pulmonary edema, looking at more genetic and hemodynamic studies, and then trialing pharmacologic prophylaxis such as sildenafil or trialing CPAP as treatments in the field, and then have longitudinal follow-ups with many of the Swedish and European studies are doing right now to characterize recurrence in cardiopulmonary sequelae. And then finally doing a formal cost-effective analysis of focus integration into race and military protocols. So key points to take home: the medics must treat the acute life threats first, as they always would. An acute onset of cough, dyspnea, hemoptysis, and hypoxemia during or shortly after a surface swimming or diving event can be swimming-induced pulmonary edema after life threats are ruled out. Median interaction between SIPE and high altitude. Use ultrasound as a validated tool to identify lung pathology, both in the hospital and in the field. And then females may have a higher incidence at low elevations, and males may have a higher incidence at moderate elevations, although relatively minimal in the grand scheme of things. Knowledge of population-specific pathology is important for medical practitioners treating that population. And again, context matters. That's an overview of kind of everything. After this, I'd be more than happy to talk about SIPE, about the masters, about really anything else. I'm just happy to be here. Thank you very much.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.